Good afternoon, everybody. We're going to get started with our next session, Neurobiology of Orofacial Pain. The session is going to be presented by two people. They're going to partner on it, Dr. Maram Taema and Dr. Qiman Gao. They're both residents, orofacial pain residents at the University of Minnesota School of Dentistry. Dr. Maram Taema, she's originally from Egypt, from Al-Qaeda. That's where she got her dental degree, as well as a master's in prosthodontics. She then came to the University of Minnesota to do her master's program in orofacial pain. And Dr. Qiman Gao, she's originally from China. She completed her DDS and oral surgery residency in Shanghai, and later a PhD at McGill University, and now she's also currently doing the orofacial pain residency program. Both of them are about to graduate really soon, and they, I think, did a great job preparing this presentation. I'm looking forward to it.
Good afternoon, everyone. Now we'll be talking about the neuroanatomy. We have nothing to disclose, but we would like to thank our Professor Dr. Estefan Moana for helping us put these slides together. Talking about the lecture outline about neuroanatomy, we realized how dry topic it is. And I think that's why they chose us, because we just had our boards. We still remember our anatomy. I'm just kidding, we already forgot it as well. So we'll have it in two parts. First, I will be talking about the basic neuroanatomy, and my colleague, Dr. Qiman Gao, she will be talking more about neuroanatomy in real life. So let's start. We'll start with a simple introduction about the nervous system. So the nervous system is composed of two cells, mainly two cells. The neurons, which is like the basic functional transmitting unit. It transmits the impulses, being a prosthodontist, I'm sorry. So it has the body and the axon. The axon is covered with a myelin sheath. It can be going from the periphery to the central nervous system, and then we will call it afferent. Or the other way around, from the central nervous system to the periphery, and then we will call it efferent. And it can be in between both, then we'll call it interneurons. And then the glial cells. Glial cells mainly is to support the neuron, to support it metabolically, and it also helps in laying the myelin sheath around it. We all know the importance of the nervous system in regulating our mental activities like thinking, learning, memory, but it's also important for pain. Nervous system is divided into central nervous system and peripheral nervous system. So we'll start with the peripheral nervous system. It has different nerve fibers. First fiber we'll be talking about is the A-alpha fibers. It's the largest, heavily myelinated fiber. It's involved mainly in the motor reflexes. And then the A-beta fiber, it's smaller in diameter, less myelinated, and this is mainly for light touch. It can be involved in pain, but that's not the usual. Then the A-delta fiber, much smaller, thinner in myelination, and this transmits mechanical and thermal stimulation. Mechanical, it's like when someone pinches you, this sharp pain, that's the A-delta, and intense heat. And then the C fibers, it's the smallest. It's not myelinated at all, but it's the most numerous in our nervous system. It transmits the mechanical, thermal pain, chemical pain, and that's the pain you feel as dull pain. And we know that as the fiber gets smaller in diameter and less myelin sheath, so it's slower. So the C fibers are the slowest. And as we go up, the A-alpha is the fastest. We will be mainly concerned about the A-delta and the C fibers, which transmits pain. The peripheral nervous system have several nerves according to their location, like 31 pairs in the spinal nerves, and then 12 cranial nerves. We are mainly concerned about the trigeminal nerve. That's our beloved nerve. It's supplying this area, it's the largest, and it's a mixed nerve, meaning it has some sensory and some motor. Okay, now let's talk a little bit more about the central nervous system. Central nervous system, it's the brain and the spinal cord. And they are, to be protected, they are in a skull and the vertebral column. To further protect the brain, there are 3 connective tissue layers protecting it, which is called the meninges. So it's the skull, then the dura mater, that's the outermost, arachnoid matter, and then the pia mater, that's the closest to the brain, and it's tightly attached to the brain. These meninges are supplied somehow by the trigeminal nerve as well. Let's have a deeper look into the brain. And that's a sagittal cut, so I'm cutting it into 2 halves. The biggest part is called the cerebral cortex. And then below it is the cerebellum. In between, there is the brainstem, which is in continuation with the spinal cord. And above it, there is the thalamus. We are also more interested about the brainstem. The brainstem is further divided into 3 parts: midbrain, uppermost, pons, and then the medulla oblongata, which is, after that comes the spinal cord. The pons is where the trigeminal nerve emerges. And that leads us to the trigeminal system. Now, let's talk more about the trigeminal system. Again, that's the pons. Again, I cut it into 2 halves and I opened it up. Okay? What can we see? These are the nuclei that forms the trigeminal nerve. So the uppermost is the mesencephalic, then the primary sensory, or the main sensory, and then final, the spinal nucleus. And because the trigeminal still have some motor innervation, there is a small nucleus called the motor nuclei, as simple as that. So all these nuclei combine together, and then they form the trigeminal nerve, which then form the trigeminal ganglion before giving birth or merging into 3 other branches. And that's where the trigeminal nerve gets its name. It's tri, it has 3 branches. Okay? The first branch is the ophthalmic. So it's like this, 3 branches. The first branch is the ophthalmic, and from the name, ophthalmic is eye. So it's supplying this area. It's supplying the eye, the scalp, frontal sinuses, the meninges. And then the maxillary branch, again from the name, it's supplying the maxilla. So it's supplying anything below the eye level, the maxillary teeth, the maxillary sinus. And then finally, the largest branch, the mandibular one, which is supplying the lower third of the face. And it supplies the mandibular teeth, the TMJ, and this is the one that has some motor fibers supplying the muscles of mastication. Now let's talk about pain. How does pain go through the trigeminal nerve? So for pain to happen, it has to go through 4 steps. First, transduction, transmission, modulation, perception. Let's quickly go through these steps with pain. So if any individual is having a noxious stimulation, which is any type of stimulation, mechanical, chemical, thermal, there will happen some tissue damage, which will lead to release of some different neurotransmitters, leading to the firing of A delta and C fibers. Okay, this slide's a little bit complicated. So when they were studying pain propagation, they studied it more on the hands and the feet than on the face. So that's how we relate the pain propagation to the face as well. So I'll be trying to explain more. So the first thing, the pain is felt at the skin receptor, and then it goes through the A delta or the C fibers, which here we call them the primary order neuron, first order neuron, which is the closest to the periphery. That's the first nerve to get the impulse, okay? And then from the first order neuron, it wants to transmit the pain or the nerve impulse to the second order neuron, which happens in the trigeminal system in the spinal nucleus, happens in the pons, the system we were explaining. The thing is that we have a lot of first-order neurons, but not a lot of second-order neurons. So second-order neuron can receive multiple information from several first-order neurons. And that can sometimes cause the referred pain. Like when a patient is having a heart attack, they usually have their pain in the left shoulder because that's the more common pathway. And that's something similar to what happens also in the face. And Qiman, Dr. Gao, will be explaining more with her cases. And then finally, through the trigeminal thalamic tract, the second-order neuron transmits the impulse to the third-order neuron, which starts at the thalamus and ends at the cortex. And that's when the patient can perceive pain. And that's when the pain is in the conscious level. So Dr. Qiman Gao will be explaining that more. I won't go through that a lot. So now, pain modulation. We know that the pain has to propagate from the first-order neuron, second-order neuron, to the third-order neuron for the patient to perceive it as pain. But also, these higher brain centers can send impulses to decrease the pain level for the brain not to perceive pain. Like when people are fighting in a war, in any kind of compact sports, when they have an injury, they don't feel it when they are like warm and fighting. And the higher brain centers try to control the nociceptive information. They inhibit it. So the patient cannot feel the pain. And if the pain is not at the higher brain center, the patient will not feel it. Have any of you were in like any kind of contact sports and had this happen to them before? I actually had it before. I was involved in a contact sport, and I broke a rib, and I continued the fight. I didn't know I broke a rib. So that's how it's done. That's a good thing, right? But as there are things that can control the pain down, they can't control the pain up. Again, the higher brain centers, for some stuff that is not felt as pain, normal stuff, they can feel it like, oh, that's so painful. So we can control the pain up and down by the higher brain center. And that's why in 2020, the International Association of the Study of Pain changed for the first time the definition of pain. Since 1979, like that was the last time they changed it. And they said that the pain is unpleasant sensory emotional experience associated with or resembling that associated with tissue damage. So it doesn't have to be like tissue damage. And they added that pain is always a personal experience, and it can be affected by the social and psychological backgrounds of the patient. And they also said that pain doesn't have to be because of nociception or tissue damage. It can change throughout life according to the experience of every individual. And they said that we have to respect any patient-reported pain because everyone can report pain differently. And also, although pain is very important as a protective mechanism, but it can sometimes be devastating for the patient. And yes, we understand that the verbal description of pain is the most easier and we can do it if the patient is saying, but sometimes patient cannot explain it. And you can judge the pain by its functional and psychological side effects on the patient. I'm sorry about this topic, it's very dry, but now we'll go into a little bit better part. It's the real life with Dr. Gao. She will be talking about the clinical implications. Thank you.
Thank you, Maram, for the beautiful slide. As we complain, neuroanatomy could be really dry. I often fall asleep when I study it. So we try to make it more fun. Wondering how many audience here are general dentists? Oh, all of you. Any nurse practitioner? Any MDs? Okay, so I designed the case similar to the scenario of your general practice. I hope this is helpful, and we see this a lot. So we're gonna have 3 stories, and what I love about this cases are I always learn more from case-based learning when I interact with the cases and involved in the cases rather than just listen to the lecture. So here we go, case 1. We call it the story we often hear a lot about. So this is a 60-year-old female who is your long-term patient in your clinic. She come here says, I have this tooth pain on the left lower side, on the teeth, and it seems like it started about 2 months ago when you did the filling, after you did the filling on me. So she also mentioned that there's a stressful life changes, that she might get a new medical diagnosis since 2 months ago. And this tooth pain actually stays, didn't go away, seems getting worse. She's really worried about it. She also mentioned that the left side of her jaw hurts a little bit. And she feels that she might need to have the filling redone. And we see a lot of cases referred from general dental clinic to us like that. So more about that tooth pain. It's on the left side lower quadrant between teeth 18 to 21. Intensity varies from 3 to 6. It's a dull ache sometimes with sharp pain upon chewing food. It's constant. When she chews food, getting worse. And sometimes ibuprofen or rest can be helpful. But how come the pain stayed for the 2 months, didn't go away? And she noticed the pain is worse in the morning and at the end of the day. Medical, family, social, psycho history. The patient do have some diagnosis, diabetes, type 2, hypertension, asthma, as they reflect. It's very well managed with medication and regular follow-up with a physician. She does have an ongoing potential diagnosis of multiple myeloma, which make her very nervous, and she's waiting for the result. And you started the clinical examination. You first double-check the tooth 19 that you did the filling about 2 months ago. It looks okay, no pain with probing, no tenderness to percussion. You also checked all the teeth on the lower left quadrant, and seems none of them are like tender to percussion. The cold tests appear normal, and the X-ray radiograph looks fine. And the only weird thing is you try the tooth loss, have the patient bite on it. It seems like every bite on every posterior teeth, she reported a tooth pain, and you cannot localize the tooth. So, what will you do? Any thought? Well, after you attended the AAOP, you probably have the knowledge. So here's a little bit more basic understanding. Referral pain is something we often see as orofacial pain specialists. And referral pain from masseter to posterior teeth are the most common referral pain pattern we see. And a clear history intake and a thorough clinical examination will help you find the diagnosis. And the most important examination is actually muscle palpation, which you probably went through a little bit this morning. So, with this knowledge, you decided to do a thorough muscle palpation. And upon palpating on the left side masseter, the patient say, aha, that's my tooth pain when you press there. And here we go. You find the answer. It's a referral pain. So you explain the patient your diagnosis and why is this happening, and you introduce her to use heat massage, try some muscle relaxant. If the symptom persists, you will consider refer them to a orofacial pain specialist. That's the first story. All right. So just to help you understand what was happening, this is what we call a trigger point. So, we all have muscle fiber in our body. It contrasts like this, coming from the fiber to bend, and then it contrasts. With repeated contraction, we sometimes get trigger point, as you see in this picture. So when the trigger point is formed, and you palpate on that muscle, you will find a muscle knot. All right, and that's where the trigger point it is. And trigger points sometimes give people referral pain, as Maram explained in the neuroanatomy, because from the first to second neurons, we don't have enough neurons taking the signals. So sometimes the brain perceives the pain at a different location. So typical trigger point referral patterns that mimic the tooth pain, which we see a lot in dental practice, are masseter, temporalis, and sometimes, more rarely, digastric muscles. So masseter, trigger point refer pain to the posterior teeth. Temporalis mostly refer to all the maxillary teeth. And digastric muscle is usually is anterior band, refer the pain to the anterior mandibular teeth, which is more rare. All right, the second story, headache. Here's a patient come, a 35 years old female with no major medical diagnosis, come here for the regular dental follow-up. She does have some neck pain following a whiplash car accident 1 year ago. She sees chiropractor, she sees physical therapist for the neck pain. She complained about a daily headache for more than 3 months. And this headache really bothers her, and she finds it difficult to focus. And she works as an accountant with a lot of computer work. In addition, she does report some jaw soreness at the end of the day, and she's aware of herself clenching her teeth at work. So more about this headache is right at the frontal region, not the typical masseter-temporalis pain we often see. Intensity varies from 4 to 6 out of 10. It's almost every day she have it all the time. And worse, at the end of the day, it's unclear what make it worse. Seems ibuprofen make it better. And she's really worried about taking too much ibuprofen frequently. So on your clinical exam, visual evaluation showed an obvious neck forward posture. Because she is an accountant, she works in front of the computer a lot. So she has a lot of neck pain. And it seems the intraoral exam, dental exam looks normal, but when you palpate on the SCM right here, the patient say, I feel that pain on the neck goes up to my forehead. That feels like my headache. So here we go, another story that we sometimes see in our dental clinic about headache coming from the neck. So I'm going to bring in this convergence theory. I hope this slide helps you understand what is going on, how come a neck pain can become a headache. As Maram explained, between the first and second order neurons, they actually merge together, and that can change the brain's perception of the location of the pain. So as you see here, this is the trigeminal nerve, V1, V2, V3, and then I'm going to highlight those cervical nerves. Oops, it's a little bit off. This figure illustrates how our nerves talk to each other. So basically, when we explain to the patient, we often say that head and neck muscle talk to each other. This is what is happening. So typical trigger point on those muscles referred, on the cervical muscles that referred to the forehead are the SCM, and sometimes temporalis is also refer pain to the forehead. We do have more muscles on the neck with more referral pattern, but that's for the more advanced lecture. So these are the most frequency cases for the forehead headache. All right, and the last case is a mystery case, which will link us to the next lecture. So this is a case published in 2006 by Dr. Nixdorf in our clinic. It's a 43-year-old male, presented with a dull ache, throbbing deep pain right at the left side upper molar region. This pain is episodic, intensity from 7 to 8 out of 10. Duration can last from 2 hours to 5 days. The pain has been presenting for 8 years, and this really impacted his work and his sleep. The patient had multiple visits to general dentists, physician, neurologist, endodontist, oral surgeons, and tried so many treatments, including root canal treatment, extractions, occlusal spin, neck adjustment massage, and even tried the treatment for trigeminal neuralgia. But none of this was helpful. The tooth pain persists. So what will you do? First, we do another clear history taking, right? We go through the details, we ask about the triggers, what make the pain worse and better, and we do a thorough clinical exam, and we didn't find anything duplicate the pain. So I want to emphasize the importance of history taking here. In this case, we did sit down, talk with the patient for more details, and the patient started to say that he noticed when there is a tooth pain episode, he does notice some nausea and vomiting and light and noise sensitivities. So what is this? This is the very key information we call autonomic features, which is a typical feature for migraine headache that Dr. Bender will introduce and Dr. Marcelo will introduce and give us more details. And this feature suggesting that this tooth pain is actually a migraine headache presenting on the tooth region. So end of the story, we give the patient some triptan medication. The patient is having complete symptom relief. So why is that? Migraine present as a tooth pain. which is very interesting and exciting. So migraine headache is a neurovascular headache. Dr. Bender will talk about it. And I just want to emphasize from what we learned with Maram's slides, our nociceptors in the dural matters are mainly the V1, the trigeminal nerve V1 branch. However, they are V2 and V3 distribution, also cervical nerves in that dural matter. So as you see in this figure, the orange color is the maxillary branch, and the red color is the mandibular branch. If there's any intracranial nociceptive fiber fired in these areas, the brain and prefrontal cortex can perceive it as tooth pain or pain in the alveolar bone. With that, I'd like to conclude my 3 stories and hope you remember all those key informations. Neuroanatomy can help you diagnose and treatment for orofacial pain. Pain signals can refer to different locations presenting as tooth pain, as headache, or even neuropathic pain. And without the correct diagnosis, we are treating the patient as shooting in the dark, and patient will feel frustrated. And a correct diagnosis leads to the successful treatment. Thank you.